The Center for the Improvement of Human Functioning International presents this luncheon lecture. Today's topic, aging bones. Your presenter, Rebecca Kirby, M.D M.S R.D.
Welcome to our lecture on aging bones. Now, if anybody in here is over the age of 30, you have aging bones. Now, for folks who are new, I want to introduce myself. I'm Dr. Rebecca Kirby. I'm a board-certified family physician. Got my credentials from Texas Tech, hence part of this accent. I'm also a registered dietitian and have a master's in biochemistry. I acquired that from Texas A&M, hence the accent. But in my early years, I was at the University of Texas working in the lab of Dr. Roger Williams doing biochemical and nutritional research, and that's in Austin, hence the Texas accent. Okay, today we're going to talk about aging bones. We're going to talk a little bit about normal aging and what is involved in normal bone metabolism with age. We're going to talk a little bit about the definitions of the thing that is out there that's the scary disease osteoporosis, and we're going to talk about what are our risks associated with that and how we might want to look at fracture risk as our real benchmark for why we might be concerned about bone loss. And we're going to talk about all those things that contribute to bone loss, how this is measured and therefore puts us in all sorts of categories, and what we can do to maintain healthy bone. And there's going to be a lot about nutritional teamwork, because that's very important. Okay, now to tickle those little gray cells, we're going to have a little quiz first. True or false? Aging is a disease. Yes. Thank you. Okay. 2, bone density declines with age. True. It is a normal part of aging. Okay. 3, loss of bone density is a disease. Well, that's kind of a maybe, because if you have too much loss, which we're going to go over conditions where that might happen, then you might end up with osteoporosis. But if it's just a normal part of aging and you're a healthy person and you know how to prevent yourself from falling down, you're not really at risk for a disease. Okay. 4, 90% of hip fractures are a result of falls. That's actually true. So the big fear is if you have bone loss, you're going to have a hip fracture. But guess what? You have to fall first. So what's the most important thing to prevent? Falling. Now, 5, death rate within 1 year of fracture, a hip fracture, is 20%. That's actually true. And we see this in people who are not healthy, primarily, and really frail elderly. Okay, 6. Osteoporosis is listed as one of the top 10 causes of death for Americans. Yeah, that's false. Okay. Now, what happens with age? Well, aging begins as growth stops. So it's inevitable. And our bone mass is achieved, our peak bone mass, around the 3rd decade. Then it kind of plateaus for about 10 years. And then after you're 40, it starts declining. But there's all sorts of things that are going on that are a normal part of aging. We have changes in our joints. Often they get a little narrower because we have a little less cartilage. We have loss of the nucleus propulsus, which is the squishy cushion between the vertebra of our spinal column. We just, in fact, have decreased water and volume in our connective tissue with age, and we have flattening of arches. Now, what is it about all of those things that they kind of have something in common? When it comes to changes in your body conformation, they can make you shorter. Okay, and we also, with age, tend to have a decreased muscle mass. We tend to have more body fat, unfortunately, and less of that protective subcutaneous fat that, children have with their pretty little cheeks, and we have less total body water. But as we age, we just don't make as much bone. And back in 1981, somebody looked at a number of people, and those are all just points on the screen, and then drew a line and showed that as you aged, you had less bone density in your spine. In this case, it was the lumbar spine, which is usually the place where bone loss begins first. Now, let's talk a little bit about bone, because it's a very dynamic tissue. A healthy bone is. And I know we tend to think of skeletons like the specimen skeletons you see. Hard bone, static, dead tissue. But bone is very much alive, because you know if you've broken one, it repairs, and it has a very good blood supply to feed it nutrients. So bone is constantly turning over. In other words, you have cells that help you make bone. Those are called the osteoblasts. I remember it because it's got a B in it for builders. And then they're teamed up with the osteoclasts, which help reabsorb bone or take old bone away so that the osteoblasts can build on some new bone. Now, there's a nice balance between the osteoblasts and osteoclasts, and as we age, we have a little less osteoblastic building activity and a little more osteoclast reabsorption activity, hence the normal loss of bone with age. Now, we think of only bones as these mineral deposits, and of course bone is a very good reservoir of minerals, but that mineralization has to take place on a protein matrix. So protein is very important as well. It's like the scaffolding that you are building the bone on. And so at least 10% of our bone is protein. And of that protein, most of it is this type 1 collagen. And the reason I actually just put it down there for you to contemplate is, we're going to talk about later, vitamin C is very important for collagen formation. So we're going to talk a little bit about nutrients and how they have to work as a team. Okay, but as we're contemplating what's going on with our tissues, we've got these nutritional factors that I just mentioned. We have genetic factors. We have hormonal, structural, metabolic. And when you think about genetic factors, people with different ethnic origins, different families within different ethnic groups, they all have a little bit different bone density. And they go from country to country, and people are different. Hormonal influences are very important in this delicate balance of our bone metabolism. We find that if people don't have enough estrogen or testosterone or DHEA or progesterone or calcitonin or growth hormone, they might not have a good bone development. And it can also happen that you get way too much of some hormones, cortisol, parathyroid hormone, or thyroid hormone. And some people with diseases where they excrete large amounts of these hormones, they can have some a change in their dynamics of their bone tissue and have some bone breakdown. Now, parathyroid hormone, actually you have to have for bone development. It's when you have too much or too little, you get into trouble. Now, I mentioned structural and activity is very important for this metabolism of your bone. It tends to be a positive effect on your bones if you're a little heavier. And that is because gravity. This is the one time gravity is your friend. And a lot of this really came to the forefront when they observed what happens with the astronauts. Because when they're up there in weightlessness, they lose as much as 1% of their bone mass per week up there in weightlessness. So when we have muscle contractions and we're pounding the ground, we're actually stimulating those osteoblast bone-building cells. And if we're really inactive, like maybe even in a hospital bed for a long time, we lose we can lose bone mass, and we can actually excrete more calcium. So, and then good nutrition. Physical activity and good nutrition, really hallmarks there. Now I want to talk a little bit about how our attitude towards the disease osteoporosis has changed over the years. I went back and looked at my old textbooks, kind of like 80s, some that predated that, and they don't really have chapters on osteoporosis like the textbooks do now. I had to find a definition in my pathology textbook. And what it talked about was osteoporosis was a disease where you didn't have enough bone for proper mechanical support. So it was all about mechanics. And then definitions have evolved. Now we are measuring bone density. And our definition now includes a loss of bone density when we're talking about defining osteoporosis. And I'll tell you, back in the pre-80s actually, when I was doing a research project on bone density in diabetic rats, there was no real acceptable way to measure bone density in a live person back then. We could do it in a rat after it had deceased, but so since then the mechanisms for measuring bone have developed, and we've got the definitions kind of centered around that. And just to mention osteopenia, that is also considered low bone mass, but the next step up is the diagnosis of osteoporosis. Okay, so remember when we were talking about, all right, so we have less bone mass as we get older, so what? But what we do want to prevent is falling down and breaking a hip or some other bone. And even though it sounded pretty ghastly that 90% of the fractures were caused by falls, only 1% of the falls actually result in a fracture. So just because you're falling doesn't mean you're going to, splinter. So what you need to do is look at what makes me at risk for a fracture. And this is some of the things that the doctor will be looking at when they're evaluating your bone health. And one of them, well, if you've already had a fracture, and we're not talking about an automobile accident type fracture, something that was a little less predictable. If there's a lot of fractures in, like, your sisters, your mother, things like that, advanced age, as you saw on that graph, the older you are, the more likely you're to have a higher degree of bone loss. However, advanced age also comes with some other risk factors like dementia, if there's poor health or frail health, poor muscle strength, impaired vision. All those things put you at risk for falling. And if you've had a recent fall, they might look at you like you have a risk factor as well. And if you had early menopause, for women under 40, that usually means surgical menopause, anorexia, which is a starvation disease, and cancer treatments that are specific for depleting your estrogen, that can also put you at fracture risk. But I want to hearten those ladies who have had early menopause, because the statistics show that by the time everybody reaches 70, their risk is the same as if they had had normal late menopause. So, catch up. Okay, more risk factor points. Body weight in older women, if they're very thin and slight, that's considered a risk factor. Okay, cigarette smoking, any amount. Alcohol. Okay, alcohol is pretty interesting. It's over 2 drinks a day. It may even put you a little risk. The big deal is heavy alcohol consumption is going to increase your risk of falls. Pretty obvious. But there was a study that showed women who drank like 1 to 2 ounces a week, these were women over the age of 65, actually had higher bone mineral density and a decreased risk of hip fractures. Wow. So moderation in everything, huh? Okay, actually low mineral density can be a risk factor for fracture risk, but you notice there's a lot of other things too. It's just one of many things. And certain medications, that's a big deal. We'll talk about those medications. Okay, other things that can contribute to low bone mineral density. I mentioned the eating disorders. Okay, if you don't get a good peak bone mass, in that second and third decade, then you're going to not have as much to lose, and that puts you at risk. And you think about all the young people and their poor nutrition and what we might have coming down the road here. If you've had a low calcium and a poor nutritional intake, that's going to put you at risk for not building a proper bony skeleton. And the hottest news is cola consumption. And this published study had a nice little graph. If you were drinking 1 to 3, you were beginning to have decreased bone mineral density. But if you were up to 3 to 7 colas per week, this is not per day, this is per week, really significant decrease in bone mineral density. And it doesn't matter if your cola is decaffeinated, it doesn't matter if it's diet, it's a cola. So take that into heart there. Low physical activity, as we discussed, that's a real risk factor for low bone mineral density. Obviously, if you've been an astronaut, you would be out there in weightlessness, and that would be a risk factor. And then, of course, hormone deficient states we've talked about. But that includes men. Testosterone deficiency, that's a risk for them, just like low estrogen can be for women. Other things that contribute to bone loss, too little vitamin D, too much vitamin A low protein diet. Now, the protein in the diet has been worked over pretty well because of the popularity of the Atkins trend. And what they've found is, when people kind of settle down to eating a high-protein diet, they don't really eat more than like 35% of their calories from protein, and that doesn't seem to be a problem with contributing bone loss. However, we do know that a low-protein diet, people who don't get adequate protein, and this is often people who are malnourished, that will affect bone mineral density. And celiac disease, which is a problem with intestinal health, and I'll be talking about that in about a month. We'll have a lecture on going wheatless. That interferes with absorption in many arenas of nutrients and contributes to bone loss. And prolonged immobilization, like I said, if you're like in a hospital bed or just not moving around, and you've probably all noticed that if you've had a cast on, the appendage that's not being used is a little bit skinnier than the one that's out there being used. Plus, tennis players will have much increased density in the bones of their active arms. So all those things like immobilization and weightlessness contribute to bone loss. Now, the corticosteroid therapy greater than 3 months. Corticosteroids, that's all your prednisone. Those are quite widely used. It doesn't matter whether they're being injected or given orally. They're a huge risk factor for bone loss. And then if you have any kind of chronic illness, besides the celiac where you have poor absorption, you may have some changes like with liver disease or chronic renal failure. Diabetes is a risk factor. And also hot off the press, depression is a risk factor for bone mineral loss. They're still trying to kind of sort out why this was. In the study, the women that had the loss of bone and who were depressed had a smaller lean body mass. That means their muscles, they didn't have as much muscles, and they also were excreting a lot of cortisol, which is part of that stress reaction. So never underestimate what depression does. It's also a risk factor for heart disease. Okay, now we talked about drugs, and I wanted to mention things that really do contribute to bone loss. Long-term use of all those prednisone type drugs, corticosteroids we call them. If people are on immunosuppressive agents, we've known for a long time the anti-seizure medication Dilantin affects bone loss. Intramuscular medroxyprogesterone, that's those birth control Depo-Provera. Those were shots that women can use for birth control. Mind-altering drugs like benzodiazepines, which are your tranquilizers, Librium, Xanax, things like that. Morphine and opiates, heparin, which is a anticoagulant agent. There's certain diuretics, we call them loop diuretics. Furosemide contributes to bone loss, calcium channel blockers, and antacids, and there's quite a list. I want to feature two that are also sort of hot off the press. And these two things, your proton pump inhibitors and your antidepressants, are in your top 10 prescribed medications. So those proton pump inhibitors, we call them PPIs for short, purple pills, and all the... Okay, the studies have found that there's a 44% increase in the risk of hip fracture. And the longer you're on that drug, the higher the risk. Just think how many folks are on that drug. And there's quite a few like it as well. Okay, antidepressants. You're at risk if you have depression, but you're at risk if you're taking an antidepressant. And that the study was done with the serotonin reuptake inhibitors, the SSRIs. They showed a 10% fracture rate in women over 50 who had been on these antidepressants, and then their control group only had 5% fracture rate. So it doubled the fracture rate. And they were twice as likely also to fall. And they showed that they had a lower bone mineral density at the hip and the spine. Okay. Now, other causes of severe bone loss, like I talked about, chronic renal failure. COPD is emphysema. If you have a hormone disease, what they call an endocrine disease, liver disease, malabsorption, treatments for malignancy, rheumatoid arthritis. And, okay, I left off osteoarthritis. Okay, there's an interesting thing about osteoarthritis. You're at risk for more falls, but folks with osteoarthritis often have more bone density. So here's a case where having more bone density doesn't protect you from fractures because people are falling. Okay, so the bone density tests now are something we call a DEXA scan, dual energy X-ray absorptiometry. And it's, like I said, its development came along pretty rapidly in the 80s. And they say that they can detect changes of about 1%. And it's used as the most accurate test for bone density. Standard X-rays, you have to have an awful lot of bony change to be able to see like 40% of bone loss before it really shows up in just your ordinary X-ray. Now, along with bone measurement came standards. In 1994, the World Health Organization put out a very important technical report bulletin. And they defined what was going to be called osteoporosis and osteopenia. And what they did is they developed a score. And if you deviate from that score by a certain amount, you are put into a risk category. So it's looking at women, adults, that are at their peak bone mass. So whatever would have been considered the peak bone mass, like in the 20s and 30s, that was the standard used. And then if it deviated from that by one standard deviation, you were still okay. But if you deviated more than that, like 1 to 2.5 standard deviations, they call that osteopenia. And then if you deviated 2.5 standard deviations, you got a diagnosis of osteoporosis. And if you've ever had a bone scan, it comes back with all of these scores. Now, this is done in a way has sort of changed our thinking of normal bone loss is now a disease. Because what happens if you look, I just take a subset of women, the folks who published this in JAMA did a study, and they found that with those new standards from the World Health Organization, 40% of postmenopausal women will have osteopenia. And additional 7% at least will have osteoporosis. That's what they found just from their studies of, well, 200,000 women over the age of 50 over 34 states. So now we're all of a sudden at risk for having a disease as we get older just because we're aging. And one thing that was brought out in an interesting book that Dr. Don Davis discussed a couple of luncheon lectures ago called Overdosed America is that World Health Organization group that put together those standards was funded by 3 different drug companies. And during those years, there were those drugs coming down the pipe that were going to be for treating osteoporosis. Now, you'll often always see a Z-score, too. Now, a Z-score is not going to compare you to somebody in their 20s. It's supposed to compare you to somebody your age, your gender, your weight, and your ethnicity. Now, ethnicity is very important because, as I said, genetics play a big degree in that. So the Z-score, if you deviate from the Z-score, it's more likely to point out that there might be something else going on with your metabolism, like thyroid or poor nutrition or smoking or medications that are affecting your bone loss. Okay, so now we have this way to measure it. And our United States Preventive Services Task Force has recommended that women over age 65 be routinely screened for osteoporosis. If you're under 60, but you've got a risk factor, you had a fracture, family fractures, all those risk factors we talked about, then possibly screening could begin then. But they don't really have any recommendations for screening people younger than 60, either for or against. There's not any good evidence yet. And what's interesting is there was a study from the Netherlands that showed that bone mineral density only identified about 1/6 of the risk factors associated with fracture, which of course we saw there was a lot of other risk factors associated with fracture. Now, what's even more interesting is our Agency for Healthcare Research and Quality has tried to put a test to seeing whether having all these bone mineral density scans while you're on therapy, if you've been put on some sort of therapy, getting them over and over again is actually making a difference in your treatment. And they didn't find any evidence that adjusting your treatment therapy based on repeated bone scans had any improved outcome. So, and they also found there's a new thing, bone turnover markers that are being used a lot to see if you're breaking down a lot of bone. They didn't see that correlated well with bone measurements or fracture prediction. Okay, so we know there's lots of things out there that have to do with drugs prescribed for osteoporosis, and I've seen some of them prescribed for osteopenia. And we're not going to really talk about all of them, but I will mention there's hormone replacement therapy. That's sort of had a bad rap lately since it's not good for your heart. There are the biphosphates. There's been a lot of studies on those, and they're not quite sure whether they really do help fracture risk. There's the estrogen-like drugs we call SERMs. Calcitonin, there's been some parathyroid hormone, and once upon a time, the new kid on the block was fluoride. Any of y'all remember what happened with fluoride? Fluoride looked like it was going to be so exciting, so I actually had an uncle who was osteoporosis, and he was enrolled in a study to get fluoride to help with his osteoporosis. And it did, for a while, help with pain, and they thought things were going really well until his spine just collapsed. And that's because even though they thought that those bone minerals were, dense and all, it created a very unsafe and a very unstructured bone, so that the bone didn't have the tensile strength and everything that it needs. So I'm always a little cautious about really new things that come around. And you have to ask yourself, when you're being presented with a medication, do the side effects of the medications outweigh the benefits? And you need to really understand the benefits. And I just wanted to repeat the JAMA study that there's at least 106,000 deaths a year that are from adverse effects of medication, and these are ones that are properly prescribed and properly taken. So always know what the heck you're being asked to take. Now, okay, so we're going to lose a bone. That's just, part of aging, but we want to prevent ourselves from falling, because having a fracture is what is the risk we're trying to avoid. Okay, here's what we're doing as we get older. We're falling down more. These are non-fatal falls. As the age group progresses, men catch up with women, and they're falling down more. But remember, these are non-fatal falls. And I noticed in the reading that it also matters which way you fall. If you fall forward or backward, you're less likely to have a fracture than if you fall sideways. So lots of things involved. So what do we want to do? We want to prevent falling, so we can prevent fractures. Now, how do we do that? Number one, we improve strength, balance, and coordination. All things that make perfect sense. We even know that the strength training helps with bone preservation, not besides just the fact that it gives you good balance to prevent fractures. We want to avoid medications and drugs that affect the balance or cause postural hypotension. That's when you're sitting down or squatting or laying down and you get up suddenly and you see little stars, you feel really lightheaded, and you're going to fall down. And there's a lot of medications that cause postural hypotension. And then anything that alters your senses, if you just kind of feel a little strange or woozy from taking a medication, that puts you at risk for falling down. Correct the poor vision. You need to be able to, see where you're going, see the obstacles, see the steps. And that goes along with improving your environment and lighting. Light things up so that you can see them. Light the hallways, improve any kind of areas where there might be not only steps, but there might be things to get around. It's interesting, they did a study on finding out when people were falling. And one of the things they found out is that people who were running around in their socks at home had more chance of falling. So you're better off wearing your shoes around the house. They also found that when these people were out doing their walking, which is very often when the falls are happening, they're tripping over cracked sidewalks. So, watch out for your walking path. Try to use something that actually has fewer obstacles. And one thing we did for my aunt, porch steps. You got concrete, and concrete on concrete is pretty hard to see. But you can do things to delineate those steps so that they're very obvious. And one is you can make some sort of fluorescent tape, or what we did for her is we put that green AstroTurf on her porch so that she could tell when it was time to step down to the sidewalk, because that was an abrupt visual change. And one thing I put in asterisk here is get rid of scatter rugs. They are a real environmental hazard. How many of y'all have tripped over your scatter rug at home? At least once, twice? Huh? So they're just obstacles. It's obvious the big obstacles, but you forget about your scatter rugs because you've got them around to prevent muddy feet, or for warming your feet in the bathroom. Put them back on the tub rim after you finish your bath instead of leaving it around to trip on. And another study found that people who slept more than 10 hours a day were more prone to falling. They didn't hypothesize why, but that was a combination of sleeping too much at night and napping. And maybe they're just so sleepy they're too groggy and they're falling down. But beware of too much sleep. Okay. Nutritional factors. We talked about protein. You have to have adequate protein. And you need to have adequate nutrients because they work as a team. You want to avoid refined foods because refined foods have very minimal nutrients. And the vitamins that always get a real green star are vitamin D and also vitamin C and vitamin K. Then vitamin B12 and folate. They actually did a study on some folks who had had strokes who were in a nursing home, and they were giving them B12 and folate to try to lower their homocysteine. And what they found is they had like a 78% reduction in fractures. So they went back and kind of looked at what they were doing. Then there's minerals: calcium, phosphorus, strontium, magnesium, zinc, copper, manganese, boron, silicon. There's a lot of really important minerals, not just calcium. And you also want to minimize minerals that interfere with good bone integrity, like the higher rates of fluoride, aluminum, lead, cadmium, tin. They can all influence the mineralization of your bones. And you say, okay, but I eat well, so I should be able to get all my nutrients from my food, which may be one reason Americans are experiencing more bone loss is we're not even eating the RDA of some of these key nutrients that we have just talked about that are important for bone mineralization. This is the percent of people who are not getting just the recommended dietary allowance, which is a very nominal amount of nutrients that help prevent deficiency diseases. Look at how low, and as you notice, the women have the highest percent of not eating the RDA. So it's maybe not such a surprise. It's more common in women, not just our hormones. Okay, now, calcium. The Women's Health Initiative put ladies on calcium, 1,000 milligrams, calcium carbonate, and 400 IUs of vitamin D. And the Women's Health Initiative has been going on for a long time. They just saw a 1% increase in bone density at the hip, just a slightly lower risk of hip fracture. So they went back and looked more closely at the data, and they found that only 59% of the women at the end of the study were taking what they were supposed to be taking. So they'd fallen by the wayside, taking their 1,000 milligrams of calcium and 400 of D. So they factored out those ladies and looked at what was happening with them, and they did have 29% fewer hip fractures, which meant that there were 4 less per year per 10,000 women. So there's still a lot of debate about, is calcium going to help you build bone? But one thing you want to remember that is all those nutrients are needed to keep your bones healthy. And there's a lot of debate, and it's true, to just regard calcium as the magic bullet does not work. Calcium has to have other factors. And there's a lot of other countries where there's not a lot of calcium in the diet. They're probably eating more whole foods than we are, but they're not having quite the fracture risk that we are. Because let's look at vitamin C. We saw that 44% of the women aren't getting the RDA of vitamin C, which does anybody know what the RDA of vitamin C is? 60 milligrams. So 44% of American women are not even getting 60 milligrams. This is kind of like a nationwide vitamin C deficiency. So vitamin C is important because it enhances the collagen synthesis. You have to have that matrix of collagen to put the bones, put the minerals on. There was a study of 994 women, and there was 277 that were regular vitamin C users, and their average dose was about 750 milligrams. It's a little bit higher than the RDA. And they found that there was a higher bone mineral density in all these vitamin C users. And there were some of them that were actually on other therapies like estrogen and calcium, and the vitamin C even gave them better bone mineral density. And then there was a PEPI study where they found that for women who were taking at least 500 milligrams of calcium, for every 100 milligrams extra of vitamin C they were taking, they had an increased increment of bone mineral density. So the more vitamin C, in addition to their calcium, the more bone mineral density they found. So let's think in terms of vitamin C. It's generally fruits and vegetables, and obviously you get 750 milligrams. You might actually not be able to eat, let's see, how many papayas would that take? About 4 to 6 or something. But those are good sources to always get in your diet. Anyway, fruits and vegetables. Now, speaking of vegetables, vitamin K. Vitamin K may be even more important than vitamin D when it comes to bone health. First, they observed that folks who had low vitamin K had increased incidence of hip fractures. It's required for protein production in the bone, and it can also help the osteoblasts, the bone builders in the bone, and it works synergistically with vitamin D. So think vitamin K. Don't forget the vitamin K. Food sources, that's why there's a little green leaves up there. Every kind of green you can think of. Kale, spinach, collards, turnip greens, beet greens, my favorite, Swiss chard, even Brussels sprouts. So a dark green leafy vegetable a day, remember, keeps the doctor away. It's my favorite saying. Okay, and of course calcium is that our bones are a very good storage vesicle of calcium, and we need that calcium to help our healthy bone metabolism. And you don't have to get it from dairy products. If you like tofu, it's actually prepared with calcium. And the firmer the curd on the tofu, the more calcium is in it. They fortify soy milk now. Sesame seeds are a good source. And then, of course, your milk and your dairy products like cheese and yogurt. Those are good sources. There's your greens again. Your calcium is not absorbed as well from your greens as it is from your dairy products. You know, that oxalic acid that when you eat spinach makes your teeth furry. That also inhibits the absorption of calcium. Good old pinto beans. And I put corn tortillas down there because they're one of my favorites. But a corn tortilla is made by just soaking corn in lime to soften it up, and then it's all ground up into masa and then made into a tortilla. So for every tortilla, you're going to get at least 50 milligrams of calcium. And in some countries, that's the major source of calcium. Okay, now, what's right below calcium on the periodic table? A mineral called strontium. And this is very important in bone mineralization. It actually may help draw calcium into the bone. And this was known quite a while back. In the 50s, they actually used strontium lactate to relieve bone pain. And then, I don't know, somebody forgot it. Until recently, there's been a lot of European studies using strontium ranolate, and they have found an increase in bone mineral density and a reduced incidence of fractures. And what's happening with the strontium ranolate is they're trying to patent it. So if you're interested in strontium, you might look at other forms like the carbonate or the citrate. Now, Another important mineral is magnesium. If you're taking calcium, you should be taking half as much magnesium as you're getting in calcium. So if you're taking 1,000 milligrams of calcium, you should be getting 500 milligrams of magnesium. And if you'd like to improve your food sources of magnesium, it's in your whole grains. It tends to be in the bran fraction. So that means if you're eating white stuff, you're not getting any of your magnesium. Pumpkin seeds are a good source, and so is cocoa. Almonds, fish, and of course your dark green leafy vegetables. Now, let's not forget vitamin D. Vitamin D is we're learning more and more about vitamin D, and it's not just for bones anymore. They did a study where they looked at folks that were getting about 800 international units a day, and they had 26% lower risk of hip fractures. Now, that's twice the recommended dietary allowance. They also found that older people with higher vitamin D levels had better muscle strength and balance. So how are you going to prevent falls? Better muscle strength and balance. So vitamin D is also important for muscles, and they found that that helps reduce the risk of falling. And in one study, they even found that it may increase protein synthesis in your muscles. So, sounds good, but do you know that half of the North American women receiving therapy to prevent or treat osteoporosis had vitamin D insufficiency? So, like, what good is that going to do? So the recommendations now of 800, maybe 800 to 2,000 international units, that 400 IU a day, maybe going out the window soon. D2, ergocalciferol, is the synthetic form, and it's better if you can take your D3, calocalciferol. I just read an article recently that they don't think D2 should even be considered for vitamin D replacement. And if you just step out in the sun, which we don't have any today, to think of that, 30 minutes will give you 20,000 international units in unscreened scan. That's the economical way. Another economical way is just to swig down a tablespoon of cod liver oil. The cod stores it in its liver. And some of the other fatty fish that are good for our omega-3s, they're also good for vitamin D. And then you'll find a lot of things are fortified. Milk, orange juice is fortified also with calcium. Your egg also has some vitamin D. And, of course, that's the yolk. That's not the white. Okay, so think about your risk. Look over all those factors that might put you at risk. You know, everything from medication, family history of falls, you know, too much, oh, did I mention too much coffee? Over 4 cups a day increases your excretion, urinary excretion of calcium. You know, no smoking. And it kind of boils down to the 3 factors that are the main things that are behaviors that help prevent death in the U.S. And that is the smoking behavior, the dietary and exercise behavior. Those all account for preventable causes of death, the top numbers in the United States. And they're also going to contribute to poor bone health. You need to optimize your nutrition, not just eating whole foods, but really looking at making sure you're getting all of those nutrients that we talked about, not just the calcium and vitamin D. And you, very, very important, need to engage in strength and balance building activities. Strength and the balance to help with preventing falls, as well as the actual exercise to improve any kind of chance of bone loss. You don't want to be immobilized. Avoid those medications that we talked about that really put you at increased risk for bone loss. And you may even need to consider a well-rounded supplement that has all those bone-preserving nutrients. And I've got some resources here that I used, and there's also resources throughout the handout. So if you have any questions, thank you for coming today. I think we have a little time for questions. They'll come around with the... The microphone. Oh, we got some papers back there.
You didn't say anything about bone spurs. How do they fit in with bone health?
Well, bone spurs often are kind of a calcification from pressure. And one of the things I read, the bone spurs can sort of throw off some of their measurements of bone mineral density. But that's not one of the things that they consider when they're doing those bone scans.
Do we have I would like your opinion on Actonel and Fosamax.
Well, those are the phosphates. And what they're supposed to try to do is cut down on the osteoclast activity that decreases, the osteoclasts are the ones that are busy with the bone reabsorption. And if you look at some of the original data that was published, that was the really hot stuff that kind of, we heard it from the drug reps, let me tell you. If you looked at the data a little more carefully, as was pointed out in that book, Overdosed America, the women who were on that drug decreased their fracture risk from 99.8% to like 99.4%. So, the jury is still out about how much those drugs really impact the risk of fracture. It's one thing to have bone minerals, but if you're falling and breaking things, that's another thing. So when you're contemplating medications, look at what actually is the endpoint. Is it just going to build up bone minerals? And some of them are building up bone minerals in your cortical bone, which is your real heavy bones like here in your thigh. Where you fracture a hip is up at the joint, and that's a softer bone we call spongiform bone. And that's where it needs to make a difference. And did it cut down on the number of fractures and deaths from fractures? So that's something that you have to take into consideration. What are your risks for actually falling and having a broken hip?
Okay, good questions.
Oh, I have a question on this cola consumption. Does that refer to all pop, all types of flavors?
Interestingly enough, it was only colas. Dark colas. Yeah. Not that all those other soft drinks are off the hook, just because they're empty calories. But yeah, the study showed it was a cola significance.
I got some information from somebody who works with Dr. Robert Marshall on bone density, and what he discovered and documented was the fact that when your x-ray shows that you have increased bone density, when it was analyzed, it was actually mineralization of the bone, which wasn't the bone. It crumbled when they were doing that. So that was from Fosamax and Actonel.
Certainly the case in fluoride.
Yeah, so it's the same thing. So those two prescriptions are really no good, and the x-ray is not showing the actual
because like we talked about, there's that protein matrix. There's a lot more to a bone than just, having calcium down there that shows up on a scan. It's a living structure that needs to be strong. And whether bone mineral density is really going to tell us that. I'll tell you with my diabetic rats what happened. I went, the study had already been done that these rats that had been made diabetic had less bone minerals. And the way they did that is they killed the rat, they burned up the bone, and they measured the minerals. Okay, so your assumption is, they have weaker bones. So my task, this was my fellowship task, was to document the breaking strength of diabetic rat bones. And when I actually did, find a way to chop them in half and document what happened, the rats were not with the bones at the time. The strength was the same in the diabetic rats. They just had smaller bones because these were not treated with insulin. But the strength was about the same.
Would you comment about glucosamine? We take glucosamine chondroitin.
Glucosamine is an amino acid that has been observed to help with the cartilage in your joints. So that has to do with osteoarthritis. And it also can help with pain of osteoarthritis. So it's part of the cartilage matrix of the joint.
Is tea in the same category as coffee?
You know, I found nothing about tea. So now that doesn't mean we're off the hook with tea. However, you know, it was interesting in the cola study because they always thought that it was caffeine in the coffee. But in the cola study, it didn't matter if it was decaffeinated. Well, of course, tea has caffeine also. We don't tend to brew it to those caffeinated amounts as we do coffee. So the jury is still out with tea.
The preceding program was presented by the Center for the Improvement of Human Functioning International in the Bright Spot for Health Lunch and Lecture Series. To inquire about additional health-related information available on DVD, audio CD, VHS, or audio cassette, simply call 316-682-3100 or drop by 3100 North Hillside in Wichita, Kansas. To discover more about the center and what we have to offer, be sure and visit us on the web at www.brightspot.org.